Hello, and welcome to Hard Conversations. This is a podcast about male sexuality, intimacy, and sex positivity, where we unpack the taboo topic of erectile issues in a safe, non-judgmental space. And now, here's your host, sex therapist, Timothy Norton.
Hello, and welcome to Hard Conversations. I'm really excited about my next guest, Dr. Howard Schubiner, who is an internist and the director of the Mind-Body Medicine Center at Providence Park Hospital in Southfield, Michigan. He is a clinical professor at the Michigan State University College of Human Medicine and is a fellow in the American College of Physicians and the American Academy of Pediatrics. He has authored more than 100 publications in scientific journals and books, and lectures regionally, nationally, and internationally. Dr. Schubiner has consulted for the American Medical Association, the National Institute on Drug Abuse, and the National Institute on Mental Health. Dr. Schubiner is the author of 3 books, Unlearn Your Pain, Unlearn Your Anxiety and Depression, and Hidden from View, written with Dr. Alan Abbas. He lives in the Detroit area with his wife of 34 years and has 2 children. We're going to be talking about 2 things today: psychogenic pelvic pain, and penises that don't get erect for psychological reasons. There's a lot of crossover between these 2 topics, and even though Dr. Schubiner primarily deals with chronic pain, his approach to treating these conditions is perfect for working with psychological erectile issues. Note to the listener, the beginning of this recording where we say hello and thanks for being on the show got cut off. So just know that I did say the things that one says when they first meet someone, and I don't just start off conversations with people asking about erections before saying hi. How can a guy have pelvic pain and it not be something structurally or biologically wrong with him?
Right, Tim, that's a great question. In fact, most people would think if your arm hurts, there's something wrong with your arm. If your penis hurts, there's something wrong with your penis. That only makes perfect sense. But when you dive deeper into what pain is, and if we have time, I can explain that a little more deeply, it turns out that statistically speaking, most pain is not due to a structural tissue damage problem in the body, which is pretty surprising. But take headaches. Probably 15 to 20 million Americans have headaches, chronic headaches. And if you ask any neurologist, the vast majority of those, 95 to 98%, do not have a structural cause for their pain. In other words, when you scan their brain and do x-ray their sinuses, you don't find sinus disease, you don't find tumors, infections, inflammatory conditions, you just have headache. It's pain. And so that pain is not due to a structural problem in the head. Well, it turns out if you look at abdominal pain, it's virtually the same thing. And if you look at pelvic pain, the vast majority of people with chronic pelvic pain do not have a structural problem where they're feeling the source of the pain. It's shocking, really, but it's true.
And could that apply to not just pain, but burning, urination burning after you ejaculate, numbness, tingling, all the golf ball in the butt feeling?
Right.
Is that?
I've seen it all.
Okay, you've seen it all?
I've had some of them myself.
Oh, man.
Yeah, it's pretty common. In fact, the majority of people have had some sort of pains, tingling, numbness, burning, at some point that was not due to a structural problem, and I have. So any and all symptoms can be caused purely by the brain, and certainly most symptoms can also be caused by a structural problem in the body. If you have, gonorrhea infection or a chlamydia infection, you have burning after urination, well, okay, that's an infection, that's an inflammatory condition that's triggering the brain to activate pain. But what happens sometimes is somebody might have a structural cause for pain, say a chlamydia infection, and their brain learns that pain. The infection gets treated, the infection is cleared, cultures are negative, but the pain can continue. And that's because the neural circuits that are actually activating the pain are still going. So when you touch a hot stove, it's not your finger that's causing pain. It's actually a neural circuit in the brain that gets triggered by the injury that causes the pain.
Interesting. So, yeah, why don't we get more into what pain is? You said that you could give an explanation of that. So, how does that neurocircuitry play into this?
Well, if you think of it from an evolutionary point of view, or intelligent design if you prefer, the brain has to be able to do two things with pain. Number one, has to turn on pain when there's an injury. And at times, and certainly if you imagine one of our forebears running across the savannah trying to chase down a deer a long time ago, and they break their ankle. Now, if you don't get severe pain, you're going to keep running, destroy the ankle, never hunt again, and die, never reproduce. So, but it's not the ankle that's causing the pain. It's the brain that's activating severe pain. It turns out that stress and emotional insults or assaults activate the exact same parts of the brain that cause pain. So the brain can turn on pain as if it were a physical injury in the absence of a physical injury, because the brain knows that's how it's designed. That's what it does. And so research shows that people who have, for example, the famous story we always tell is there was a guy who jumped off a scaffolding in Britain a few years ago onto a nail. The nail went clear through his boot, screaming, yelling, rushed to the hospital, medication. They take his boot off. The nail is precisely between his toes, no injury at all. But that pain that he had was severe and real.
And so why?
Well, it's a protective measure. Children who are born without the ability to feel pain often die at an early age. So pain is a warning signal. It's like a smoke alarm. And it's warning us there's something wrong. When you break your arm, your pain is warning you, telling you there's something wrong and that you need to go to the hospital and get a cast or whatever. When you're in a situation in your life where your partner's cheating on you, or your boss is criticizing you and micromanaging you, or your kids are acting up or using drugs or whatever, your brain can produce a warning signal, and that signal can be pain. It can also be anxiety or depression, or it can't sleep. But pain is a common alarm mechanism that the brain knows how to do. And that pain can be burning, tingling, numbness, shooting pain, sharp pain, throbbing pain that comes and goes. It's up to the brain to whatever it wants to do.
So why does it stay chronic?
Well, what happens is the alarm signal goes off to tell us there's something wrong. And if someone's talking to you and you don't listen, someone will typically talk louder.
Okay.
So that's kind of what the brain is doing, because it's trying to get your attention. So it can talk louder, it can talk longer. And then what happens, and this is the critical point, most chronic pain is due to the fact that the pain itself causes fear and worry and attention to it and monitoring of it. And that fear and attention and monitoring puts more focus on the pain. And the more you worry about the pain, the more the pain itself is driving the danger alarm mechanism in the brain to create more pain. And that's the vicious cycle of chronic pain.
Okay. And that's something that I do hear a lot with guys who are struggling with maintaining erections or achieving erections, is that they're afraid they're not going to get another one. And they'll probably get one when they masturbate, but they're afraid that they're not going to get one when there's another person in the room.
Exactly. The more fear, the more worry about it, the more pressure to perform, the worse it gets. And that's why when there's less pressure, if they're masturbating, for example, or there's not a person in the room but a computer, then the pressure's off, and then the system works fine.
So, is it? How do we get better? Do we just face our fears? Is that?
Well, yeah, it's first of all, from my point of view, is making an accurate diagnosis, knowing what the problem is. Mm-hmm. If one thinks they have a structural problem or hormonal problem or whatever, it's going to be pretty hard to turn off the fear of it, to turn off the danger signal. So the first step is recognizing what the problem is. And that's usually done through getting normal medical testing, making sure there's nothing structurally wrong, which is usually pretty easy. Hormones are normal, CAT scan is normal, physical exam by a doctor is normal. And that's usually the case. As I mentioned before, 90-some% of people with chronic pelvic pain don't have anything structurally wrong with them. So that's the first step. The second step is freeing yourself from the fear and the worry. So once you have the diagnosis that you know there's, quote, nothing wrong, doesn't mean the pain isn't real. It's very real. It's not imaginary. Anybody who says it's all in your head is either ignorant or cruel or both. But if you can get past that, and you can realize it's not your fault, there's nothing wrong with you, this is just part of being human, then every time you get a discomfort or you're in a situation where you need to perform sexually, you just need to stop worrying about it, stop focusing on it, and train yourself to calm in the face of pressure or stress or pain. Calm your brain. And when you do that, then you're turning off the danger signal. And then you get better.
So there's a couple things that I want to address with that. So one of the things you said was that, and this is what we run into in dealing with mind-body medicine all the time, is people don't want to think or hear, hey, it's all in your head. And you describe that statement as ignorant and cruel. Could you elaborate on that? Because on the one hand, you're saying, the brain is causing the pain. The brain's in the head, and so that's it. Why are we not saying that it's all in your head?
Well, that's an important distinction, because all in your head has pejorative terms. It implies that the pain isn't real. You're imagining it. Well, that's not true. It's real pain, because all pain is caused by the brain. It's implying that it's your fault, that there's something wrong with you, that you're nuts, you're wacko, you're mental. That's not true. As I pointed out earlier, I've had many instances of pain in my stomach, back, neck, rectum, scrotum, you name it, over the years. It comes and goes. And I'm not crazy or mental or deficient. It's part of being human. So that's the key, is taking the guilt away, taking the shame away, and recognizing that these symptoms are very real and not someone's fault. So that's why we say it's not in your head.
Right.
It's in the brain. It's the brain that's doing it. Right. And you can't control your brain. The brain has its way of doing things, and you can't go in there and just turn off the pain in your brain. You have to work with the brain and train it and rewire it and reprogram these neural circuits that have become learned over time.
Yeah, and how do we retrain those neural circuits?
Exactly. Well, that's what we do, and that's why I've written books on this. That's why people at the Pain Psychology Center in Los Angeles, as you do, teach people how to do this. And the key is recognizing that the pain is not dangerous. When you recognize that it's not dangerous, then you start training your brain that it's not dangerous. So when it occurs, you train yourself to separate from it rather than to react to it. So the reaction is fear, frustration, worry, constant monitoring, stopping what you're doing, acting like you can't do anything. And so the opposite is recovery. It's acting like it doesn't matter. It's treating yourself like the pain doesn't matter. It's kind of like a bully. Bullies feed on fear of their victim. The more fear, the more the bully is emboldened, and they keep tormenting their victim. But when the victim either stands up to the bully and fights back and says, you can't do this to me anymore, and punches him in the nose, or the victim says to the bully, oh, you're saying I'm stupid? That's a good one. Ha, ha, ha. I don't care.
Mm-hmm.
So you're in essence laughing at the pain. Now, is that easy to do? No, not always. It's simple, but it's not always easy to do. And it can take several weeks or months for people to retrain their brain.
Yeah, especially if it's been happening for a long time.
You'd be surprised how, yes, that's true, but it's amazing how sometimes quickly these neural circuits can turn on and off, because they are, in essence, neural circuits. It's not a hardware problem. It's a software problem.
Interesting. So emotions. So you were talking about fear, and I recently watched one of your talks. I think you gave a talk at Google some time ago, and there was mention in that, and there's a lot of talk in the psychogenic pain world about pain being connected to emotions. Could you speculate on what emotions might be coming up for someone with erectile issues?
Well, yeah. The research shows that emotions activate the exact same areas of the body as an injury does. So the brain is wired to produce pain or other symptoms when emotions occur, because we feel like we're in a situation which is dangerous. If we feel like someone's judging us, that would qualify as feeling endangered. Maybe not physically endangered, but emotionally endangered. But it's the same thing. The brain responds the same way.
Mm-hmm.
So if you're performing in work, gymnastics, golf, or sexually, you're still performing, and it's a question of how do you feel judged or not? Do you feel embarrassed or not? Do you feel guilty? Those are powerful, powerful emotions. Am I good enough? Powerful feelings that can produce significant and real symptoms, real psychogenic symptoms.
Right. And then I've looked at Unlearn Your Pain. I've looked at that book quite extensively. And there are a lot of passages in there where you're writing about your emotions.
Yeah, exactly. There's several ways to deal with the emotions that come up in our daily lives, and if we don't deal with them, you can either not recognize them or not express them. We can suppress them, pretend they don't exist. Anger is a common one. Many people are taught anger is bad. You shouldn't be angry. You shouldn't be an angry person. Bad people are angry. Violence leads to horrible things, and violence does lead to horrible things, but anger is a healthy and normal emotion that oftentimes we need to help our patients recognize that it's there, allow themselves to feel it, allow themselves to express it in a safe and healthy way, for example, in writing or when they're alone verbally, not necessarily to the person. Guilt is a very powerful emotion that people commonly feel that can trigger pain or other psychogenic disorders. Unexpressed sadness and grief, same thing.
And as you say that, I think about how different anger is to fear. And I wonder sometimes when people are, when working with people on this, if I can see that when they're angry about it, it almost seems like they're less afraid, that they're kind of moving past that. They're empowered.
Yeah, I've seen that many, many times because the life stress and the life situations that where someone feels powerless, for example, at work or in a relationship, creates a tremendous amount of fear if you're powerless to do anything. And that fear activates the danger signal, which can cause pain or other psychogenic disorders. But when you're trapped and feeling powerless, oftentimes you're angry about that. And anger leads to action. Anger is a powerful and positive emotion that leads one to express oneself. And as long as you're not expressing anger in a way that creates violence or creates harm or creates defensiveness, or you can ruin a relationship easily by expressing anger. So what we've learned to do is help people express anger in private ways that don't ruin relationships, and then go back to the relationship to express, to be assertive but civil, if that makes sense.
It does. And I'm I deal with this stuff a lot, so I'm trying to put myself in the shoes of a client, and we kind of glossed over some of this stuff, and I'm wondering, guys are told they have CPPS, they have chronic pelvic pain syndrome, and they have prostatitis, and they have a host of other things. And are you saying that this process and these mechanisms that they'll apply to those conditions, or are any of those separate from this psychogenic pain?
Well, what I'm saying is those conditions are labels which often mean nothing. Chronic pelvic pain syndrome is a label which means virtually nothing other than you have pain.
Chronically.
And it sounds horrible. And if you look it up online, you can read about people who suffer for it for years and keep going from doctor to doctor without any cure, because when you treat a psychogenic pain syndrome as if it were a medical syndrome with drugs or injections or surgery, oftentimes it'll just get worse because you're not addressing the underlying cause. And the reason they give a diagnosis of chronic pain syndrome or chronic prostatitis is usually because they haven't found anything. So they're just giving it a label which describes, in a sense, where the pain is, or pudendal neuralgia is another one of those. It's saying, well, it's pudendal, which just means pelvic. Neuralgia means pain that's like a nerve pain. It's completely meaningless. So those are three diagnoses that we commonly see that are, in fact, a psychophysiologic or a psychogenic pain disorder, period. There's nothing wrong physically.
But with a nerve, can't they get in there and see that the nerve is damaged?
No, not at all. When you're given a diagnosis of pudendal neuralgia, it just means you have nerve-like pain.
Nerve-like pain.
Yeah. And so, like you said, remember you were saying earlier, well, can it be tingling? Can it be burning? Can it be scratchy? Can it be itchy? Can it be sharp and lancinating? It can be any of those things. And so if the brain chooses a pain that is like a nerve-like pain, then they'll call it pudendal neuralgia. But it's really meaningless. That term is given, like I say, when the tests are normal. Mm-hmm. When the CAT scan or MRI of the area is normal. So what does that mean? It means there's no tumor, there's no infection, there's no inflammation, there's nothing structurally wrong. And it's just hard sometimes to explain that to people because we as a society are so steeped in the knowledge that pain equals physical damage. And shockingly, most of the time, that is an incorrect statement.
And it does just get worse with medical treatments. That kind of reminds me of, with the erectile issues, a lot of guys, especially if they start taking one of the PDE5 inhibitors, Viagra, early on, that eventually they don't work very well. And if you've been taking that for 10, 15, 20 years, I mean, it's only been out 20 years, you might need a higher dose, so you might start having way more side effects. And it might have been something that it could have been treated, with dealing with emotions and things that we're talking about and retraining the brain, had you just not had a medical treatment to begin with.
Right. And most, when you look carefully at the studies, there's a high likelihood in many medications, including opiates, including Viagra, etc., that the effect of the medication is a placebo one rather than the actual effect of the medication. And so over time, the kind of placebo effect wears off a bit. And, because we haven't, as you point out, you haven't addressed the underlying. You haven't addressed the underlying issue. The underlying issue is ongoing and may get worse over time. I saw a guy who had testicular pain so bad that he ended up having his testicle removed.
Oh, man.
But the reason I saw him, of course, is that the removal of the testicle didn't stop the testicle from hurting, because the pain wasn't due to an abnormal testicle. And in fact, they knew it was not an abnormal testicle before they removed it, but they were at their wits' ends, and he was in such severe pain. It turned out that in this case, he had found out that his wife had a, quote, emotional affair with one of his friends. And that precipitated the onset of the testicular pain, kind of like getting kicked in the nuts, so to speak.
Sure.
And then they smoothed things over, and things were going fine for a while. And then he found out that no, she wasn't having an emotional affair with this guy. She was actually having a full-blown sexual affair with this guy. And then the pain skyrocketed through the roof and wouldn't go away. I saw a guy who had got hit in the scrotum on a basketball court by a ball. You know how when someone's going out of bounds, they throw the ball real hard back into the court and hit him square in the nuts, and he doubled over. How many guys have that happen to them? Millions. He doubled over and walked it off. He can finish the rest of the game, and the pain never went away. So he had an injury, and the injury healed. There wasn't like anything was wrong. He went to numerous doctors, but the brain took that pain and just kept it going. And the more he worried about it and feared it, the worse it got.
Fear that there was something wrong.
Fear that there was something wrong, and just fear of the pain itself. And frustration at the pain, and frustration at the doctors for not finding anything, and frustration at the doctors for not doing anything or doing things that don't work. And then getting invasive procedures that are even more scary, like injections or there's a diagnosis, another similar diagnosis is pelvic floor dysfunction, pelvic muscle tension, which again, in my mind, points to a psychophysiologic disorder. And some of those people get internal pelvic therapy. That's not pleasant. And it's embarrassing, and it's uncomfortable, and they're pushing on the muscles, and they're trying to make the muscles relax, and maybe the muscles relax for a while, and then they get tight again, because the muscles aren't the problem. The muscles aren't damaged or diseased. They're just reacting to tension in the brain.
What role does a person's environment play? I was watching your talk, and you were talking about repetitive strain injury. I don't know what that is, but that, and you commented that in a work environment, and I was just wondering, work environment, pressure of marriage, does that impact these symptoms?
Well, oftentimes the brain will choose, so to speak, a symptom that makes sense in some way, makes medical sense. For example, RSI is pain with typing, basically. Pain with writing or typing for the most part. And so, it can occur in the elbow or other joints, but it usually refers to wrist pain and hand pain, finger pain with typing. And so you're typing, and then you get this pain, and maybe you're getting this pain because you're overloaded at work, or deadlines are coming, or your colleagues are obnoxious, or your boss is ruthless, or micromanaging, or you're not getting promoted, and all those things can come out in the hands. And what is the brain saying? Get out of there. Don't work. You shouldn't be typing. It's too much for you. So the message is there's something wrong with your job, but the interpretation of the message is often there's something wrong with my hand or my wrist, or the ergonomics of the situation is really bad. So you get a new chair and you get an ergonomic better keyboard or whatever, all those things, and maybe it helps for a while, but the point is that you got to treat the underlying cause, which is in the brain.
One thing that I've noticed working with these clients is that in those situations, sometimes they do respond quite well to a physical therapy. And I have a theory about why that might be, and I was wondering your thoughts on that.
What's your theory?
My theory is that there are some pelvic floor specialists out there, some physical therapists in any profession, and in fact, all doctors before penicillin, I feel probably had really great bedside manner and really psychologically sound ways of communicating with people, so that they were able to do all these things that you're talking about: face their fears, feel hope, believe that they're going to be okay. All the things that doctors today are telling them that they shouldn't feel, right? That they're going to have a condition for the rest of their lives, and there's really not much they can do other than manage of it. That a really good practitioner instills that sense of you're going to be good. You're going to be this. We're going to work on this, and you're going to get better. It's
that and more. First of all, so there's three major components of a very powerful clinician-client relationship, and this has powerful effects. One is giving an explanation that makes sense. So if the provider and the patient agree on the explanation, that's a powerful force binding them together. And the explanation can be your pelvic muscles are tighter, that you need to change your ergonomic thing or whatever. It doesn't matter what the explanation might be. Your chi is off, or your chakras need adjusting. Any of those are perfectly valid explanations as long as both parties agree on it. The second thing is then you need a technique, something to do. So the technique of the physical therapy or the acupuncture or the adjusting the chakras or whatever that is powerful again because you believe it. And the third part is the hope and the optimism and the relationship of a caring provider. And so when you put those together, you get a very powerful effect that in the psychophysiological disorder, that's all you need. And research has shown that, for example, in acupuncture, studies showed that a kind and caring acupuncturist had much better results than a brusque and non-caring acupuncturist. Sort of makes sense, obviously.
Yeah. So explanation, technique, hope.
And relationship.
Okay. I love that because that's so inclusive. I hate ruling out all the other disciplines and everybody, but that's really saying as long as you and your client are on the same page and you have hope and you have a path, that's what really counts.
When people are coming to me, because my explanation is what I consider to be the truth, that there's nothing when that's the case, when there's nothing structurally wrong and that it's the brain doing it. To me, that's, from my point of view, it's the best path because it doesn't require somebody else to treat you. You treat yourself. Number one. Number two, it's cheap and inexpensive. You're not getting long treatments and expensive treatments for the most part. And it instills self-efficacy in the person, that they can take care of it. And then over time, which is often the case, new psychophysiologic or psychogenic problems occur because they're still human, they have the tools to deal with them. So when I see somebody who had an acupuncture treatment and their symptoms completely resolved, I say, oh, good, now we know it's your brain. Because acupuncture actually works on the brain. When you get a nerve, symptoms completely go away. When you get a chakra adjustment, symptoms completely go away. From my point of view as a medical scientist, I'm saying, instead of saying, oh, wow, it's a good thing you got your chi corrected, I'm saying, no, that was a great mind-body therapy or a great placebo therapy, however you want to think of it, because all those 4 characteristics were in place and symptoms went away. And because we're looking for helping people eliminate their symptoms rather than simply cope with them.
And I have a feeling that a few hundred years ago, the way that a doctor, or a witch doctor, the way somebody stayed in practice was being really good at that, and saying, okay, this is what you've got to do to get in alignment with the gods that are, bestowing these injuries upon you and this pain upon you. And because of their status in their community, it had a really profound effect on people.
Oh yeah, completely. If you look at healing in native communities and healing, across centuries, you find that the explanations make sense within the context of the community. It's often delivered by a powerful and respected shaman or doctor or whatever. There's this famous story of a Native American young man in the Pacific Northwest, true story. And he would see all these native healings, these shamanistic healings, and he thought it was all a bunch of crap. He thought, oh, they're just, it's just all hocus pocus and for show. And so he decided to join the training, become an apprentice, to be a shaman himself, so he could expose this, this whole thing. So they taught him all the things and the different incantations and the rules and the tricks. And one of the tricks was they used to have this thing where they would, if someone had, say, abdominal pain, they would put their mouth to the person's stomach and they would suck out the bad humors and they would spit them out. And they would spit out all this blood and guts and stuff. Well, it turned out what they had done prior to putting their mouth on the person's abdomen was put a bunch of junk in their mouth, bite their tongue so it got bloody, so their own blood was there. And when they spit it out, there were whatever, feathers and guts, whatever it was they put in their mouth was there with blood. And so it was very, it had a great show. It had a really powerful effect on people. I mean, the bigger the effect, we know the greater the placebo effect. Shots work better than pills as placebos. Surgery works better than shots. So anyway, so he was ready to do his own healing. And this young Indian princess came with abdominal pain. And she was suffering so much. And she was so beautiful. And he did the treatment just like he was taught. And she miraculously got better. And he's like, hey, this is pretty good stuff. So he didn't expose it. He became, he used it because it works.
I like that point that you say surgeries work better than shots. And I think about the context of these surgeries. First of all, our shamans are these a lot of men and women in white lab coats in tall, clean, sterile buildings that have people admitting you and upheld by structures and insurance policies and waiting rooms. And then you go in there and that's quite a show. And then there's a surgery, there's these instruments, there's anesthesia and all of the various things that are going on and other people standing around and assistants. And that's a pretty big deal.
Yeah, the higher tech, the more elaborate and the higher tech the intervention, the stronger the placebo effect, the more it costs. the stronger the placebo effect. That's been shown. Pills that are more expensive have better effect on pain than pills that are less expensive. You can get very elaborate treatments for back pain where people take your blood and mix it up and centrifuge it, or your bone marrow and inject it. And people are claiming, you can cure almost anything with that. You can go to Germany for back pain and spend $30,000 on these elaborate treatments. And, the farther you go, and I had a patient who, young woman who had horrible pain, horrible fear. And I worked with her and she didn't get better. And I worked with her and she didn't get better. And then a year or so later, she traveled to Brazil. She went into the countryside. She went to the sacred compound of this healer named John of God.
Yeah.
You heard of him?
Sure.
He's well known. Yeah.
Yeah.
He does workshops in the States here as well. And she he had her lie on her back and put her hand over her heart and pray and think and meditate or whatever, and miraculously, she got better. So more power to him. It worked.
Yeah, I think the longer I do this, I try to suss that out in the beginning of treatment, like what treatment they believe in the most, generally speaking. So in grad school, I remember reading this study where one of the best indicators as to whether a psychotropic medicine was going to work, like an antidepressant or something, was that a person believed it was going to work.
Yeah.
And oftentimes, someone will say, "Do you think I need medication?" And I'll say, "Hey, look, I'm not a psychiatrist. I can't prescribe you any medication, but I'll just ask you point blank, do you think it's going to help you? Because that's going to make a really big difference." And I had somebody just go ahead.
No, when I write a prescription for something, I tell people how it's going to work and why it's going to work and how beneficial this will be. And if they ask about the side effects, I'll say, yeah, there can be these side effects, but they don't occur, and most people don't get them, but most people do get the benefit. So I'm using the placebo effect of the medication to my advantage as much as possible.
Yeah. But then we run into, so even when there's the explanation, the technique, relationship, and hope, if they have some intense underlying stressor or source of anxiety, the symptoms are going to return.
Right. That's one of the part of our treatment is to look at their life and see what's going on. Are they in a dangerous situation, physically dangerous, emotionally dangerous situation? Is there some boundaries they need to set? Is there something they need to do? The other thing is that people who have adverse childhood events, who have had abandonment, emotional abuse, physical abuse, sexual abuse, assault, are much more likely to get these kind of psychophysiologic disorders. And sometimes it's necessary to take steps to deal with the traumatic events that are currently going on in their life or have gone in their life in the past.
Yeah, definitely. And one of the reasons I wanted you as a guest was I feel like a penis not getting hard, having to do with emotions is not even nearly as big of a leap as thinking of, like a burning or an ache that lasts for months and years at a time. That could be caused by emotions and an avoidance of emotions and compounding fears.
Or simply by this vicious cycle of pain leading to fear, leading to more pain.
Yeah.
And it's, from my point of view, it's sad that we've gone on a path where that possibility is rarely recognized in most people with chronic pain, when in fact it's the most common cause of chronic pain. And so our medical profession has veered in a direction which is highly technological. And I'm not against technology in medicine. I'm a physician, and I value the advances that have been made in the last 70, 80 years. But we've thrown out our understanding of the effects of the mind and the brain on the body.
Yeah, what's up with that path? Why did we throw out so much when we started to get a handle on just basically on penicillin and on some of these drugs and surgeries?
Well, so I'm not an expert in the history of science, but several things have happened. One, of course, is the rapid rise of technology. So technology becomes so effective for certain things that we feel that it will be effective for all things. 30, 40 years ago, with the rise of all these antibiotics that we had, we thought we would cure all infectious diseases, and turned out that wasn't the case. And so there's the tendency to think that technology will solve problems. On the other hand, there's also been a degrading of psychology, a backlash against Freud and Freudian analysis, because some of his theories were a little bit wacko and off the rails. And so people threw out all of his theories. But he was a giant, and he had really important things to tell us about the effect of the mind on the body. And so that kind of got thrown out at the same time. And psychiatry itself went in a direction of biological psychiatry, thinking that we could solve our psychiatric problems by looking at neurotransmitters and by psychiatric medications. So those three factors, I think, are the ones that I would point to.
So what is the shift going to look like?
Yeah, I think the shift is profound, but in some ways it's extremely simple. I mean, how hard is it to recognize that, for example, I have a friend who, when she was a little girl in elementary school, she got, one day she came in from recess and had a note on her desk, and it said, she read it, it said, "We don't like you, you're not like us," something like that, just mean girls stuff. She looked at it, she looked around, it wasn't clear who sent it, and day after day she kept getting those kind of notes. And within a week or two, her mother took her to her pediatrician because she was having stomach pain. So the pediatrician felt her belly. He didn't order any tests, he just felt her belly, realized that it was fine, and he looked at her and he said, "Honey, is there something bothering you?" It was so simple and so profound. And she looked at him and said, no, not at all. But she knew exactly what it was. So he made the connection for her. The next day, after recess, she took the note. She didn't read it. She dropped it in the trash. And she got a couple more notes, and she didn't read any of them. She dropped them in the trash. They stopped coming, and her stomach got better. It was a profound example of wisdom, because the wisdom is that when you have people who have common syndromes in the absence of any, bleeding or tumors or infections, and simple tests don't show anything, most commonly it's a psychophysiologic disorder. And so if we would recognize those, if people would recognize them in their own lives, if families would recognize them, if that was part of our culture, if it was part of our medical culture and our medical diagnosis, it's really not that hard. The big shift would have to occur in doing less invasive procedures for chronic pain.
Yeah, that's really gotten out of hand.
The cost of chronic pain to our society is more than the cost of cancer, diabetes, and heart disease combined currently.
Wow.
There's a huge, we're spending billions and billions, estimated $60 billion a year on chronic pain.
And is the majority of that like back surgeries, or is it a lot of are the costly meds? Or
it's around 10 to 20 billion dollars in back surgeries, roughly $10 billion in injections. I figured these out rough. These are rough estimates. Don't hold me to the numbers.
Okay.
There's less money in opiates, but more deaths,
Right.
and
those are
more suffering and more addiction.
Yeah. It's staggering, and I find it sometimes pretty frustrating when you see advertisements or people talking about those kinds of things when we've seen so many people recover from mind body techniques, from facing fears and processing emotions and reducing anxiety.
And the effects of our mind body techniques will only get better over time as more people recognize these disorders, recognizing how common they are, recognizing them earlier, and people having support for using these types of therapies from their friends and family. As opposed to now, oftentimes someone will say, hey, I read this book about this kind of mind-body connection, and I think that's the cause of my pelvic pain and my back pain and my headache. And then their siblings or their parents or their children say, oh, are you kidding? That's ridiculous. Go see a real doctor.
Right. And there's no support. But even that step, have you learned a trick along the way where when somebody's talking about something that sounds like psychogenic pain, to offer your ideas? I've kind of learned the hard way that unless they come to me because they've heard about what I do or what I'm talking about or what I know, that people don't respond really very well to it. If you say
people can be very defensive because of the same problem of feeling it's pejorative and people assuming that their pain's not real, they're not validated. So yeah, the first thing that you always want to do is to validate their pain, is to empathize with them, is to make them know that their pain is real and that they are truly suffering. So you have to do that right up front. And then you can ask what they've all done and what path they've been on, because oftentimes they've been to doctors and they've tried a whole variety of things that haven't worked. And then you can begin to ask about what it's like. And so I've got a whole method in that I've written about in my books about how to more accurately diagnose this condition. So the medical testing is negative, first of all. Second of all, that the characteristics of the pain or the symptoms fit into a psychophysiologic pattern. For example, they may turn on and turn off. That's typical of a neural circuit problem. They may be better in the morning and worse in the afternoon, or they're triggered by sound or light or something that suggests that it's triggering the brain. There's a whole variety of those things that we look for. And so that gives us more clues that it is a psychophysiologic or psychogenic disorder. And then we're looking at kind of the circumstantial evidence. Did it start at a time of great stress? Do they have adverse childhood events? Is it worse with stressful situations? Have they had other psychophysiologic disorders at different points in their life? And you put all that together. And then at some point you have to say, well, I know how much suffering you've had, and I know that you're not crazy. I know this isn't all in your head, but it turns out that many people, including myself, have had symptoms like this that are caused by a neural circuit. And you might be interested in reading about that or looking into that.
I like the neural circuit term, as opposed to saying, this might be caused by a repressed emotion.
Right. It takes the psychology part out of it and puts it in the neurological type of disorder. And we've talked in our community of doctors and psychologists and social workers and physical therapists who work in this vein. We've talked a lot about that, and we are coming to, we like there's a variety of terms we use: neural pathway disorder, neural circuit disorder, neurophysiologic disorder, psychophysiologic disorder, neuroplastic disorder, neuroplastic pain disorder, etc.
Yeah, those are good. Because like we were saying at the beginning, literally everything happens in your head, in your brain. You can't see, you can't hear, you can't breathe if there's something wrong with your brain, and your brain processes. You don't even know you're in reality without the use of your brain. And we might not be in reality, right? We might all be a part of a computer that's just tapped into our brains. But it's a meaningless statement. It's all in your head. Yes. So our ability to have this conversation is taking place somewhere in our head.
There's been a tremendous amount of advances in neuroscience, the neuroscience of consciousness, and also the neuroscience of how our brain controls our body. It turns out that we don't see with our eyes. We see with our visual cortex in the brain. And basically, we see what our brain expects to see. We hear what our brain expects to hear. We feel what our brain expects to feel. So these are all neural circuits. And the neuroscience term that people are using for this is predictive coding. The brain codes for what it predicts will happen. If you expect to have pain every time you bend over, and this is not a conscious expectation, it can be, of course, but it's really a subconscious. It's a brain expectation and a coding, a neural circuit of having pain when you bend over. Every time you bend over, your brain is actually turning on pain. And it's up to us to recognize what's going on and change that pathway.
And we might be expecting to not get an erection or expecting to lose an erection.
Exactly. It's a very powerful thing. And research has shown that that expectation effect has powerful physiologic effects on the body. People who are told that if you take people who are given a smoothie to drink, and you tell half of them it's a high-calorie smoothie and the other half it's a low-calorie smoothie, even though the smoothies are all the same, the people who got the high-calorie smoothie have their brain turns on secretion of the hormone ghrelin, which is produced when you're satiated, when you've had enough to eat. So you think you're eating, you think you've had enough to eat, your brain responds by turning on the hormone, which says, yeah, you've had enough to eat. That's a pretty amazing study.
That is amazing. And you mentioned sight and hearing. I've heard some amazing studies with that as well, with seeing things that we are expecting to see, or not seeing things that we're not expecting to see.
Exactly. There's the famous one with the gorilla,
Yeah, where everybody sees an intro to psych where they're passing the basketball to one another, and a gorilla walks right through this group of people passing. I remember I watched that in a probably 300-person auditorium at USC, an intro to psych, and then they asked us to, everybody had to raise their hand and say, did you guys see a gorilla? Maybe 30 or 40 people raised their hand. And I was not one of them. I was like, there was no gorilla. And then they show the video again and there's a gorilla.
The story I like to tell about that is my wife every morning has the exact same breakfast: sliced apple, granola, yogurt. And so that's what she has. And one morning, she was up early and I was still in bed and our room was dark, and she had an extra slice of apple, and she came up to the bedroom. It was all dark. She took the apple and she just fed it to me, basically. I opened my mouth and I bit down on it. And my immediate and powerful reaction was disgust. This tasted horrible. It turned out it was a peach.
Oh.
But it was a good peach. It was not a rotten peach. And it turns out my favorite fruit is peach.
Wow.
But my brain was expecting a crunchy apple, and I got a soft, sweet sensation, but I didn't taste it as sweet at all. I tasted it as disgusting, as rotten. My brain turned on the sensation for disgust and rotten sensation in the mouth purely because of expectation. And it's amazing that could have happened. It's so powerful.
That is amazing. Did you read the Lisa Feldman Barrett book about emotions? And she talks about her 12-year-old having a sleepover party, and they put lemonade in a catheter or something like that, and everybody was just so grossed out, like thinking that they were drinking pee. and yeah, it's our brains do those things.
Yeah,
in so many ways.
I mean, I pity. You're a police officer. You get called to a park. You get called to the scene of something. You're on a chase. And, you get there and what do you see? Well, you see what you're programmed to see, what you expect to see, what you're afraid of seeing. And, sometimes police officers in a situation where they shoot innocent people or kids even, because their brain is registering something that is not really there. It's really scary.
It is really scary. So what are you working on at the moment? What's in the works for Dr. Schubiner?
Well, we've written a couple books for patients. We have a new book for professionals called Hidden from View with the Dr. Alan Abbas, a fantastic and wonderful psychiatrist from Halifax. We recently, last year, we published the first study to show that one psychological intervention for pain is actually superior to another. And that was the case where we compared an emotional expression intervention that we devised to the standard cognitive behavioral therapy intervention for people with fibromyalgia pain. We're working on a back pain study at the University of Colorado in Boulder. And we've randomized people to getting a mind-body intervention versus a placebo injection or a treatment as usual. And all those patients are getting functional MRI of the brain pre and post the intervention. And those results will be coming out this year, hopefully. So we're doing research. We're teaching a lot of people. We're teaching seminars for physicians, nurses, psychologists, social workers, physical therapists, health coaches, all over the country. So, we're just trying to make this paradigm shift happen sooner or later.
Yeah, and you're doing really great work, really inspirational work. I'm realizing that I haven't done the best job of making the analogies between a lot of what you're saying to the erectile issues. And even as you were talking about that last process of assessment, it sounded like all of that stuff could really apply. Like you get erections when you're alone, but you don't get them when you're with other people. And there was an experience that where this started happening, and it's been happening ever since. And I was just wondering if, with that in mind, if you had one piece of advice to tell clients out there with erectile issues, and one nugget that you could leave them with, what would that be?
For the most part, assuming that, again, there's no major hormonal or vascular or neurologic issue, which is the vast majority of people with erectile dysfunction situation, the best advice is to recognize that you're not damaged, that you're perfectly normal, and try to be in the moment and try to enjoy what you're doing sexually, as opposed to worrying about what you can't do or what might happen or what could happen. And those thoughts will come up, but you have to just keep going back to the moment where you can hopefully be as engaged as possible in what's important and what you're doing, and in yourself and in the other person, not so much out of your head, and in the other person. That's probably the best piece of advice, really, because if you're all in your own head, so to speak, your brain's going to get in the way.
Right. It really is going to get in the way.
Exactly.
All right, Dr. Schubiner. Well, thank you so much for your time and for this interview. I think there's been a lot of really helpful information, and thank you so much for the work that you do. You're really a pioneer out there, and you're doing good stuff.
It's a pleasure, Tim. I really appreciate being here.
One thing I wanted to ask you is, how can people find you on the internet and out in the world?
My website is unlearnyourpain.com. Unlearnyourpain.com. So that's really the best way to find me. People can friend me on Facebook or on Twitter, but through my website, and my email is available there as well.
Okay, good. All right. Well, have a wonderful rest of your day and weekend, and I'll see you around.
Take care. Bye-bye.
Thanks to the show's executive producer, Robin Morrison. Thanks to Kat Murphy, director of social media. Thanks to Team Scrub for the music. Thanks to the sound engineer, Ravi Carmen. Thanks to Brian Hui for naming the show. Thanks to Alex Pitts for the intro. Thanks to Arlene Asuncion for the logo. You can find this podcast at hardconversationspodcast.com or wherever you get your podcasts. You can locate me on Twitter at Tim Norton LCSW or on my website for my private practice, timnortontherapy.com. You can also email us at hardconversationspodcast@gmail.com or call into our hotline at 662-626-4276. That's 662-MAN-HARD. Thanks to all my friends and family for brainstorming this show with me. Shoutouts to the sex-positive community, including sex educators, sex therapists, sex coaches, other fellow sex podcasters, sex surrogates, academics, the sexual health medical community, sex workers, the tantric community, and everybody else involved with having hard conversations. Bye-bye.